The board is going in and out for some reason.
Hello, and welcome to the Alabama Public Health Training Network. I'm Carolyn Miller, State Perinatal Division Director at the Alabama Department of Public Health. Thank you for joining us today for our program, Talking with Parents and Caregivers about Safe Sleep. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in this program. Also, the handouts, sign-in sheet, and evaluation are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will expire on January 1st, 2024 for nurses and August 31st, 2024 for social workers. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching it on demand, it is considered non-classroom hours. Before we get started, I would like to introduce our presenters today. Dr. Dina Maxwell with the Bureau of Family Health Services at ADPH and Kathy Pounds with Gift of Life. Thank you for being here. I know you both have a lot of information to cover, so let's get started. Dr. Maxwell?
Thank you. Good morning, everyone. I am Dr. Dina Maxwell. In way of history and why I'm relevant to this discussion, I work part-time for the Department of Public Health in the Bureau of Family Health Services. I'm also a board-certified family physician in practice in Tuskegee, Alabama. But what Carolyn may not have known is that in one of my previous jobs, I worked in the newborn nursery at D.W. McMillan Hospital in Bruton, Alabama. And so we attended C-sections, and we attended to newborns in newborn nursery. So this is kind of bringing me back to something that I did a lot of for a while. I haven't done much of it in recent years, but it's always good to kind of go back and refresh and stay on top of what's going on as it relates to keeping our babies safe. So we're going to spend some time today talking about safe sleep, primarily from the viewpoint of the prevention of sudden infant death syndrome. So we have objectives which are listed on the slide. One of my goals in doing presentations is not to read to you because I feel that people can read for themselves. So the slides are listed here. I will talk through the slides from a frame point of who, what, when, where, and why. Ever since I was in elementary school and middle school, if I had a project, a presentation, a book report way back then, that's how I would frame the discussion and help decide what would be important for us to discuss. So who are we talking about? We're talking about babies, but more specifically, or in a more broad context, we're talking about caregivers, we're talking about family members, we're talking about anyone who cares about little children, whether you're a parent, whether you're an aunt, whether you're an uncle, whether you're a big sister, big brother, everyone has a role to play in helping to keep our babies safe. What is the issue? The issue is that we're still losing too many infants to sudden infant death syndrome. One infant death from SIDS is one too many, especially when we have tools that we can use to help prevent those deaths. Where does this occur? Well, it occurs everywhere, but we're going to spend a few minutes today talking about the numbers for our nation and the numbers specific to the state of Alabama. When does it occur? By definition, it occurs within the first year of life, but as we talk through the slides, we will see that we do tend to see more cases in the 2 to 4 month age range. And why does it happen? Big question mark. We'll talk a little bit about the etiology or pathophysiology of SIDS, but what we'll learn from that is that we still don't have a specific answer as to why. So those are objectives. Those are the things that I hope you all will listen for and find present on the slides today. So what is it? SIDS is an acronym for Sudden Infant Death Syndrome. By definition, it is a sudden death with no identifiable cause after a systemic review and evaluation has been done. Inherent to the definition of SIDS is a subjective review of information, but also part of that is an objective review of information. Sometimes we'll go back and ask families, well, what happened? How was the child before this happened? And so I want to highlight that because as we define SIDS, using objective data can make our definition a little more difficult. You can only imagine someone who has just lost a child unexpectedly. You know, losing a child, period, is traumatic, but to just put your baby to sleep and go wake them up for feeding and they're dead. Imagine trying to give an objective history as to what happened. You're either going to have one or two extremes. You're going to have the parent that is so distraught that they can't tell you anything, or you're going to have the parent who is so detail oriented. Well, maybe she coughed that time. Well, maybe he did this. Well, maybe he did that. So I wanted to kind of bring that out because it's inherent to the definition, but I think at the same time it makes the definition a little more difficult because trying to gather that data is just difficult. We always say hindsight is 20/20. We look back and we say, well, maybe it was this, or maybe we should have done that. And so again, as we talk about this, the definition is there, but there are some areas where we probably hope to move to more concrete data in defining this issue. Now, as I was preparing for this talk, another term came up that I don't quite remember from my time in newborn nursery. And there's an error on this slide, and we'll get corrected slides. The title for this slide should be Sudden Unexpected Infant Death. So different from SIDS, that is SUID or SUID. Sudden unexpected infant death is the unexpected death of an infant that occurs before 1 year of age. That's a broad category. And so when you start to look at SIDS data, you'll sometimes see organizations use these terms interchangeably, but they're not totally interchangeable. And so when we talk about the sudden unexpected infant death, this is any infant death less than 1 year. An evaluation investigation will be done, and usually you can find a concrete cause for that child's illness. So the most common causes of this death, of sudden unexpected infant death: entrapment, suffocation, trauma. This is intentional trauma or unintentional trauma. Cardiac arrhythmias, metabolic diseases. So these are oftentimes diseases that present within the first month of life, and we may not be able to define it until the child has already passed away. And within this category is SIDS. And so I mention that because it can be a little confusing. They're similar, but they are not the same thing. So in this same vein, about 1/2 of all of the sudden unexpected infant death cases are attributed to SIDS. So it's kind of like when we say all SIDS cases fit into SUID, but not all SUID cases are SIDS cases. So I just mentioned that because you'll see that in the literature. And one of my goals in doing presentations is I want people to be able to hear something on the news, see a journal report, and kind of be familiar with what they're speaking about. All right, so this slide we're going to come back to in a little bit later on. So why are we talking about this? Why are we still mentioning this in 2022? Why haven't we in 2022 found a way to identify who these infants are and, you know, I'll say give them a vaccine, but that wouldn't go over well, but do something to prevent these cases? Well, we're still talking about it because nationwide about 3,500 babies die every year from SUID. So remember, that's all classes, all categories under the age of 1. But when we look into that further, about half of those cases will be SIDS deaths. So that is roughly 1,300 babies that are dying before the age of 1. And so on one scale, some people may say, well, that's only 1,000 out of all the babies born in the world or in the country. But again, these are babies who hadn't even had a chance to discover life, to even reach any potential. And so I think that is still entirely too many. And as we continue to talk, it's entirely too many because there are places that we can intervene and have better outcomes. So in 2020, there were 1,389 deaths due to SIDS. Now, what we can see is that over the last 30 years or so, SIDS deaths have dropped. In the 90s, we saw a decline in the number of SIDS cases reported nationwide. While that is good news, we do notice that there are some disparities within that. So even though overall the rates have decreased, when you look at certain ethnic and racial groups, we see that they have higher rates of SIDS deaths, particularly African Americans and Native American and Alaska Native children. And so we need to pay some attention to that because every child's life is valuable. And if we're making progress for the majority groups, we need to do some things to bring those minority groups up to those same rates of improvement. Another interesting fact is that we see increased rates of SIDS cases in child care settings. And so I don't want people to take that as a negative reflection on child care. It is just a fact of the matter. And part of that probably has to do with the number of children that they're having to put to sleep and watch over at any given time. You know, child care is a very real reality for a lot of people. And so we can't just dismiss it as we just won't use child care. We need to continue to work to see how we can make child care settings safer. And lastly, another interesting fact is there's an increased incidence of SIDS death in male children. All right, so when we talk about SIDS in our state, so we're going to go a little bit of a roundabout way to get back to why this matters for our state. But if you if you have religious affiliations, as the pastors say, just go with me, I'm going to get there, but we're going to go around to get there. So when we talk about sudden infant death syndrome in our state, we have to have a conversation about infant mortality and infant morbidity. Now, for people sitting in this room and some of the people listening to the satellite, well, you know what that means. But the average person may not understand what that means. So we're going to do a few definitions, and then my hope is that this will tie together on the last point of this slide. So infant mortality simply refers to the death of an infant before his or her first birthday. Period. We're not specifically speaking SIDS, SUIDS, infant death before the first year of age. The infant mortality rate is the number that we use to tell how good a job we're doing or how not so good of a job that we're doing. In public health, we like numbers, we like statistics. We've got to convert whatever we're talking about into a statistic so that makes it relevant for the powers that be. So you will hear a lot about infant mortality rate. So the infant mortality rate is the number of infant deaths for every 1,000 live births. Now, you can imagine that if infant mortality refers to the death of an infant, if we have a high infant mortality rate, that is not a good reflection. And so unfortunately for Alabama, we have had one of the highest infant mortality rates in the country for a long time. There has been a lot of work done to say, well, why? Why is this the case? And some of that has to do with the reason that is so important. So when you talk about infant mortality, you're talking about the health of moms and babies, but that is an indirect reflection or direct reflection of the overall health of your society. If we don't do a good job taking care of moms and babies, it does not bode well for the overall health health of our society. And when you look at the infant mortality rates for Alabama over the years and the overall health stats for Alabama over the years, we see that there's a direct correlation there. And so a lot of work has been done across a lot of different agencies to work on that. And we were all very excited. I think it was 2019 when for the first time we saw a significant drop in the infant mortality rate for the state of Alabama. I can remember being here at Public Health and people were like, did you see the report? Did you see our numbers? Because a lot of the people in public health are working directly to impact those numbers. One of those you'll hear from later today. So for 2020, the infant mortality rate for our state was 7.0, which is improvement from the previous rate of 7.4. But when you look at the national rate of 5.5, it is still higher than the national rate. And again, when we talk about health disparities, you still see disparate numbers in certain racial and ethnic minority groups and populations. So when we talk about infant mortality, historically, we have not done the best job in improving those numbers, but we really have made gains and strides over the last 5 to 10 years. So in Alabama in 2020, we had a total of 404 infants to die before 1 year of age. That's 400 babies across our state. When we look at the causes of death, SIDS was the third leading cause of death. There were 43 babies that were determined to have SIDS in 2020. Other leading causes of death were low birth weight, preterm births, and neonatal sepsis. So again, SIDS was the third leading cause of death. So when we look at this picture, I asked Google to give me 400 things. So we think this is 400 people. We'll assume so. And so when you look at that as a pictorial, to think about these being all babies under 1 year of age, that should be striking. Even if you're not a parent, if you're not a caregiver, you know, if you're human, seeing 400 babies that are no longer here should make an impact on you. Of these 400, if we were to, if I can get this to work, and I may not. So roughly 20, maybe so people, but the first 2.5 rows would be the number of babies that we lost to SIDS deaths. So again, you'll keep hearing me say, one child that we lose to SIDS is one child too many, especially if we have tools to try to improve that outcome. So what is SIDS? Well, we know it's an acronym, but what is it? Why do babies, what happens with SIDS? Well, the most correct answer is we're not 100% sure. We don't know from a pathophysiological standpoint exactly what happens that makes some babies more prone to this outcome than others. If you start looking at this and reading about it, the most widely accepted model is a triple risk model. And it says that there are 3 circumstances that must occur in concert in order to lead to a SIDS death. So what's interesting about that is if we have one of the 3, those babies don't usually die. But if we have each of these 3 things happening at the same time, then the outcome is SIDS. So we're going to jump ahead 1 slide and come back. So I put this in here because I was watching one of the morning shows and there was a tag that came across, have we cracked the case of SIDS? Have we found the cause of SIDS? Piqued my interest, so I figure it would probably pique other people's interest. And so when I was preparing for this talk, I went back to try to find that because sometimes we hear things on mainstream media and we think, oh, they found a cure for SIDS or they know what happens to SIDS, but we don't. But this was an interesting study. It was a very small study about this enzyme that they thought could predict infants who were at higher a higher likelihood of dying or having a SIDS outcome. And so I just mention this because as a practicing physician, I try to stay on top of what's out there. What are the patients hearing? What are they saying? And so I mention this because this was one of the most recent publications that said we may have found a cause for SIDS, but we haven't. But this particular cause will feed back into that triple risk model that I mentioned previously. So I'm actually going back a slide. So the triple risk model says that there are three categories or occurrences that need to happen to contribute to a SIDS death. So there is an infant issue. There is an issue as it relates to developmental timing, and there are multiple environmental issues. So just the word about the infant themselves. What is described is a vulnerable infant, or they'll term it intrinsic factors that are unique to that particular baby. So we don't have a firm handle on this, but the thought is that there is a brain abnormality that results in problems with reflexive or protective mechanisms. So normally if you fall asleep or if you are not breathing well, something triggers in your nervous system and you wake up or you take a gas. Think about people with sleep apnea. They have apneic episodes, but at some point the body is like, hey, your oxygen's getting too low. Hey, you're building up CO2. I need you to breathe. And people will gasp. And that is frequently what family members and loved ones come and say. They sound awful when they sleep. They sound like they can't breathe. So our babies, we think, have some issue with that process. There's something with the brain development that may not work as it should. There are areas of the brain that are responsible for wake and sleep states that may not be functioning properly. Genetic factors. The previous slide talked about an enzyme deficiency that could be related to SIDS. So when they say genetic factors, we have not identified a genetic cause of SIDS. You know, hemophilia, sickle cell disease, Huntington's disease, those are genetic diseases. We know what the genetic cause, but in SIDS, we're not sure about that. But there seem to be certain genetic issues or partial expressions of genes that may predispose these kids to have an issue. Developmental timing. This was interesting for me to read about. So we said by definition that SIDS is any child, sudden unexpected death, under 1 year of age. That's the definition. But when you start to read this data and read the information, most of the deaths occur between 2 to 4 months of age. And so the working theory is that this is a critical developmental period. You know, we talk about moms taking folic acid and things even before pregnancy because we know that the neurodevelopment of the baby starts in utero. But we know that that process isn't complete to well into their late teen years. And so there are phases of development that happen. And the working hypothesis is that during this 2 to 4 months of age, there are some compensatory mechanisms that may not yet be in place that would allow that infant to kind of rescue themselves should an event occur. So you've got intrinsic things to the infant, you've got developmental timing, and the big area is our environmental triggers. These are things that are external to the baby. Positioning is a part of this. Infection, sleep, environment, very big category of things that we can talk about and we will talk about in a few minutes. And these all offer places where we can intervene and try to improve the data as it relates to SIDS deaths. So at the end of the day, we don't entirely know. We have a lot of different pieces to this puzzle, but we haven't yet identified that one central piece that brings all of the other pieces together. So even though we haven't identified that key piece, that unifying piece, we do still have a lot of information. You know, unfortunately, we've lost quite a bit of babies, but we've been able to learn some things, and the goal is to try to improve outcomes for babies as we move forward. And so one of the things that we have identified when we talk about SIDS are risk factors. These are entities or situations or different things that put these babies at higher risk for a SIDS death. And so while we may not be able to have that silver bullet or that smoking gun, we still have opportunities to improve outcomes for our babies. And we're going to talk about doing that via risk factor modification. So when we talk about SIDS, there are four main categories into which we can assign different types of risk. So general risk are things that are kind of intangible. They are things that have been identified. They may or may not be things that we can directly impact. So under this category, low birth weight. That one is a little questionable because as we've learned more, we know what we can do to help with improving the birth weight of babies. But at the end of the day, if we've monitored mom through pregnancy, the baby is measuring small, the baby is meeting other milestones with measuring small, there's not a lot we can necessarily do to impact, or we don't know yet what we can do to impact that. Race or ethnicity. Remember, we talked about disparities amongst different racial and ethnic groups. And gender. Male children tend to have higher rates of SIDS death. Neonatal risk. So neonatal risk, again, has to do with kind of those intrinsic things or intrinsic factors with the baby. So babies that are small for gestational age, babies that are born prematurely, and babies that are born with developmental defects or delays. So general and neonatal are some of those kind of fixed things that we may not be able to directly impact, but these other two risk categories, maternal risk and environmental risk, we really have opportunities to make headway in improving outcomes as it relates to SIDS. So maternal risk factors. When we talk about these maternal risk factors, they're maternal risk factors, but we'll see they're tied directly to some of those intrinsic infant risk factors that we talked about. So on the slide, you can see all of the things that we know increase the likelihood that a child will have a SIDS outcome. Smoking, drug use, maternal age, poor prenatal care, or no prenatal care. In 2022, we are still finding women who have no prenatal care. We're finding people who, for whatever reason, don't present to care until they're 5 or 6 months pregnant. And, you know, it's hard to believe, but some of them didn't know, or denial set in, but they just didn't know. And so even though we have made things available, we're pretty much offering all of the free, prenatal care, we still have people who won't get prenatal care. Another factor is short interpregnancy interval. These are our moms who have babies back to back to back to back. And we know that increases the risk of sudden infant death syndrome. Now, these are maternal risk factors. These are things that mom can do differently. But when you look further into this, these things affect the neurodevelopment of the baby, which brings us back to that triple risk model. Smoking, drug use, what mom does, the baby does. And so there are issues with development in utero that may cause problems once the baby is born. These are also risk factors for prematurity and low birth weight infants. The other thing that comes out when you look into some of these is that these problems can also cause placental insufficiency. And so that's another thought, that maybe there's something with the placenta that is causing issues with this baby in utero. So these are all maternal risk factors, but they directly correlate to those intrinsic factors for the baby themselves. Okay, so environmental. This is a big, broad category. And this is the one where everybody can play a part in helping take care of these babies. a lot of different things under here, and we'll talk through some of them. So sleep position. We all should remember the Back to Sleep campaign. I remember that. We know that babies who are in a prone position or laying on their stomachs for sleep have an increased risk of sudden infant death. We're not entirely sure why. You would think it would just be the possibility that the baby's face could become compressed against the mattress, but it doesn't seem to be that that's the only risk. There's some thought that possibly babies, when they sleep like that, they're rebreathing exhaled air, and so there's a wonder if CO2 is involved, carbon dioxide. There was even one thing I read about potential toxins or fumes from the mattress itself. So I'm not sure yet if we know definitively why the prone position is an issue, but we know for sure that putting babies on their back improves sleep outcomes. Smoke. So we talked about maternal smoking. This is secondhand smoke. This is exposure to smoke. These are people who smoke in the home. When I did a lot of pediatrics, one of my pet peeves with my parents would be, well, I don't smoke in the house. Well, that's nice to know. And I put on a jacket or a sweatshirt and I go out on the porch and I smoke out there. Well, good. Well, do you wash your hair? Do you air out your skin? Do you get that smell and those chemicals off of your person before you let this baby cuddle up on your chest, under your neck? Well, no. Well, we would appreciate it if you would do all of those things if you don't smoke around the baby. What's interesting, though, as a little aside, is when people quit smoking, they often come in and say, my God, did I smell like that? Because they have no clue how that smell permeates everything they do. So secondhand smoke is huge. Trying to convince parents that even if you smoke outside, you're still exposing this baby to smoke is something I'll continue to do, and we need to encourage people to rethink that. Sleep environment. So sleep environment is huge. You know, when people find out they're expecting, they want to do their nursery and set up all of the cute things, but all of the cute things can lead to problems for the child. When we talk about sleep environment, babies should be asleep alone in their own bassinet crib. They should have a firm mattress. They should have nothing else in the crib, and that's a hard sell for some parents who have dreamed of this nursery since they were like 12. Put it in there, take a picture, and take all of that stuff out so the baby can sleep safely. Bed sharing. This is another hard one, especially usually for mamas. Well, I want to cuddle with my baby, and they need to nurture, and we need to bond and all of this. Well, the data is clear that people who co-sleep with infants of a certain age, those babies have higher risk of SIDS death. Similar to bed sharing is also, we have to take into consideration nap time. We have to take into consideration people who sit in the recliner or get on the sofa and they're going to put the baby to sleep, and sure enough, they put themselves to sleep too and they fall asleep. We've also seen in the most recent edition of the guidelines that came out last week from the American Academy of Pediatrics that there's definitely an increased risk in people who do nap time with on the sofa. Specifically, it says people who lay on the sofa with the baby to go to sleep. And so sometimes we don't think about that when we think about bed sharing. So if you're putting the baby to sleep, put the baby to sleep, put them in their crib, bassinet, or whatever you have. And then there's a question or debate about swaddling that I probably won't get into too much. But I will say, once infants are able to roll over, swaddling is not encouraged. You have people who will swear by that, and you're not going to convince them otherwise. And that's okay, because if it calms a screaming baby, I can understand that. But once that baby is able to roll, then we really need to kind of discourage swaddling for these babies. So just pictures of things that we probably shouldn't do. You know, the crib is whimsical, it looks inviting, but there are, you may not be able to see it, 2 pillows in the crib, 3 or 4 teddy bears, bumpers, and a blanket in the bed. And so that is just a problem potentially waiting to happen. This picture on the bottom, my bottom right, your bottom left, sleeping in a car seat or a bouncy seat, again, is not recommended or advised. A firm, flat sleep surface. Now the other picture is cute. It's a dad and a baby. We don't know if they're in the bed or on the couch, but I put it there as a reminder that we have to be mindful of nap time as well. People know about back to sleep and they know about putting babies to bed, but nap time is still bedtime in essence, and so you have to think about that as well. Now, if we can get this to work, we have a very short video about a dad who took a nap with his child. And interestingly enough, this dad is a pediatrician. And so we'll hear in his words, if we can get it to work, the short video.
As a new dad, I was just ecstatic to have my first child and to have a son. It was an emotion that it's indescribable, and when you speak to other new parents, I think they'll talk about how your life is different after that. I didn't have any intentions of falling asleep with him. I was holding him and sitting on the couch and watching TV. I just fell asleep. And when I woke up, Charlie was gone. I didn't think that SIDS could happen to me, but it did happen to me. And it can happen to anyone.
Charlie's Kids was formed on what would have been Charlie's first birthday. We knew that we would always honor and remember him, but we wanted other people to hear his story too. And more importantly, I think we wanted to know that other parents wouldn't experience the same grief and heartbreak that we have.
All too often, people think SIDS is just something that happens to families, and they don't realize that by putting your baby to sleep safely, you can help prevent a SIDS death from occurring. The message of safe sleep is of less. Less is more, less is safer, and that is the way that they should prepare their baby's sleep environment.
I think as we learn more and we've become more educated, we're understanding that there are ways to prevent most of these deaths. And it's so simple. Parents need to put their babies to sleep alone on their back and in a crib for every single sleep.
They don't need to be co-sleeping. They don't need a bunch of stuffed animals and thick, heavy blankets. They are warm with just a pajama and a wearable blanket.
Your baby's worth it. Keep them safe and practice safe sleep.
All right, so I wanted to, there are plenty of stories on the internet, but that one I thought was unique because he was a pediatrician. His wife was a kindergarten teacher. This illness and this syndrome is not a respecter of person. It doesn't mean that they're bad parents. It means that we made a decision, and maybe when we know better, we should do better. One of the key elements for that is back to sleep for every sleep. I think we have done a good job of honing in on back to sleep, but when my sister had my young niece and nephew, I wanted to put them to sleep and let them sleep here, but back to sleep for every sleep is something that I think needs to stick out with us. And just like he said, he didn't intend to fall asleep, but he did, and they woke up and the baby was no longer with them. So the last few minutes we're going to spend talking about what are things we can do to lower the risk for SIDS in our children. Prevention is key. This was my key to remind me to say that. You know, we talk about an ounce of prevention is worth a pound of cure. There's no cure for this, so prevention is our only option. Education. That's why we're here today. We're trying to bring this topic to people not only in healthcare, but people who take care of kids, people who have kids that they care about. Everyone needs to know about this. If you babysit, if you keep your niece, if you keep your grandchild, you want to be aware of these issues and what we can do to have positive outcomes. We need to talk to everybody, grandma, granddad, the parents, the healthcare team. The healthcare team, not just being the pediatrician, the lactation consultant, the midwife, whoever encounters people who have newborn babies. Everybody is a part of this team, and everyone needs to know the messaging to help prevent these outcomes. So this is a happy baby, and so I chose the happy baby because there are some good things. There are some things we know that we can do that actually decrease risk. It's not all doom and gloom. Breastfeeding, encouraging breastfeeding, seems to offer a protective benefit against sudden infant death syndrome. I don't know the mechanism, but breastfeeding is just good. We know that across multiple arenas of health for infants, and we're starting to see that breastfed infants have some benefits later in life. So breastfeeding is good. Pacifier use. Pacifier use when they go to bed or when they're put to bed seems to be a protective benefit. Now, I just said breastfeeding. So my breastfeeding folks are going to say, well, why are we giving the baby a pacifier if we're breastfeeding? Well, the caveat for pacifier use in breastfed infants is once breastfeeding has been well established. Once this baby is on a routine and they latch and they nurse with no problem, you can consider using a pacifier just at nap time and bedtime. Room sharing. Room sharing is different from bed sharing. So room sharing is having the infant in the bedroom with the parents up until 6 months of age. The baby should be in a crib, bassinet, their own sleep device. Some people, I think we had one time there was the cardboard box campaign. That's not the name of it, but I'm sure Kathy can fix that when she comes up later. But you know, as lightly as we take it, not everybody has a crib, not everybody has a bassinet, not everyone has a play yard. Thankfully, there are multiple programs, some of which through our state, that can provide these things for patients. But I think sometimes we assume that people have everything that they need. And so those are tools that can help make room sharing possible. Fans. So there is a little bit of back and forth in the literature on this. It is thought that fans help with overheating, and overheating is known or thought to be associated with an increased risk of SIDS. But the other thought about fans is that it may offer some tactile stimulation that helps with arousal and wake with the baby. So there's a question mark by fans, but it is one of the things that you'll see mentioned. And then immunizations. And the thinking behind immunizations is that it helps decrease certain childhood respiratory infections. Infections in turn lead to problems with respiration. And so immunizations as a tool to prevent sudden infant death. Education, educational campaigns. We remember, I think most of us should remember the Back to Sleep campaign. Well, as we learned more and began to understand better, we needed to expound on that campaign. It wasn't just important to put them back to sleep. It was important to put them asleep alone in their own bed or crib and on their back. So Safe to Sleep is a campaign, website, flyers, brochures, to all types of information helping to bring the message of the importance of safe sleep for babies. Since the inception of the Safe to Sleep and Back to Sleep campaigns combined, we've seen a 50% decrease in SIDS deaths. So the messaging is beneficial and it is working. But again, one SIDS death is still one too many. So I also always like to tie in what we're doing here in public health to help impact. I mentioned to you that for the first time in years, we have seen the infant mortality rates decrease in our state. They are currently at 7.0. Even though that is still higher than the average, that is much better than where we have been. And that is a direct result of a lot of the work that's been done by different groups here within the Department of Public Health. They didn't tell me to say this. Carolyn didn't know I was going to mention this, but I feel like we need to give kudos to our folks who are out here making things better for our infants and for our moms. So one of the programs that we have is the perinatal program. The perinatal program is responsible for today's satellite, and the program encourages cooperative relationships among healthcare professionals and institutions to ensure medically effective and cost-efficient perinatal care and to raise awareness regarding infant morbidity and mortality. So today we're doing that. We're working cooperatively with myself, with Miss Kathy, to help bring a message out here to hopefully influence people to think about safe sleep practices. Another program here is our family planning program. So people will say, well, family planning just says people won't get pregnant. Well, that's not all it says. It stops and says, well, hey, do you want to have a baby right now? No. Well, when do you think you might want to do this? Can we help you plan for when you might want to do this? And so one of the goals of, or one of the outcomes of the family planning program is that we have seen improvements in teen pregnancy, so young maternal age, so that's a risk factor for SIDS, but we also work to decrease or increase the space between pregnancies by saying, hey, do you really want to, have another baby right now? So again, short pregnancy, interpregnancy times, and young maternal age were part of those risk factors for maternal risk. So although family planning isn't technically a SIDS prevention program, it is working to do the work to decrease SIDS outcomes. Well Woman program, that's another program that was founded to help have healthier moms with the hope of later them becoming healthy women to later become healthy moms. And so Well Woman looks at identifying and treating cardiovascular disease, so hypertension, diabetes. Again, healthy women become healthy moms. And so again, those are 3 programs just within the Alabama Department of Public Health that are speaking to SIDS prevention. Another program, the March of Dimes, we're familiar with that. And so in preparing for this, I did a little bit of a history lesson. It started with the polio initiative, then it went to birth defects, and now they've incorporated preterm births. And so the March of Dimes, their tag is leading the fight for the health of all moms and babies through advocacy, education, and research. The March of Dimes partners with an organization, Zeta Phi Beta Sorority Incorporated, which is a historically Black Greek letter sorority. They have partnered to do the Stork's Nest. So again, the Stork's Nest doesn't say I'm here to prevent SIDS or promote safe sleep, but what the Stork's Nest does is identify high-risk women, usually young women, and gives them prenatal education, and in turn offers them incentives for completing the education. Incentives like a play yard, a bassinet, a place for their baby to sleep. And so part of what we do with public health and with education in general is we have to reach people where they are. Those of you that are sitting in the studio that are participating in the satellite, we have to take the message back to people who may not come to this, who may not log in to see this. But if you're an aunt, if you're a grandparent, if you're a caregiver, if you're watching a child for a church member or a friend, you can put that child back to sleep. And so I think we all have a role in promoting safe sleep and preventing SIDS deaths. So, in conclusion, I hope that I addressed my who, what, when, where, and why. I hope that we have just a little bit better understanding of the framework of what SIDS is and what we can do to impact the outcomes as it relates to sudden infant death. My hope is that we can continue to participate in educational activities, not just through our roles in public health, but in our personal lives and in our communities as well. And with that, I will stop and see if we have any questions.
Thank you, Dr. Maxwell. We don't have any that have been emailed in. Do we have any questions from our audience? Katrina?
I'll ask a question. Dr. Maxwell, you mentioned that car seats aren't a safe place for babies to sleep. Now, I have to tell you, when I had my baby in that car seat, I'd bring them inside, and if they were still asleep, I'd leave them in the car seat until they woke up. What would you say to me if I were one of your patients?
So I would say I totally understand that because with nieces and nephews, I have done the same. But I think when you know better, you do better. And so especially when in preparing for this, you realize how fortunate, how blessed you are that that didn't happen, what he experienced. And so even though it's a hassle, I think I would encourage you, take that baby out just as gently as you can. But you know, that's the reality for a lot of people, and I understand that. The problem is we can't predict which baby is going to do fine and which baby is not. Thankfully, most babies do. And if as a parent you're okay with that, then that's, you know, ultimately that's what it has to be. But it seems pretty concrete that the baby should be asleep on a flat surface. So I too was convicted of some practices that we need to do better. But just understanding, yeah, that's easier. You got 5 or 10 more minutes. You can unload the car. You can do whatever. But in those 5 minutes, is it worth potentially not having Dr. Hinkey's experience where you come back and the baby is not breathing? So I totally understand that, and the parent just has to decide what level of risk they're okay with.
Any other questions? We will take a 10-minute break, and then Kathy will be joining Dr. Maxwell at the table for her presentation. So we'll be back in a few minutes. Welcome back, everyone, to our webcast on talking with parents and caregivers about safe sleep. Thank you, Dr. Maxwell, for an excellent presentation. You gave us a lot to think about, not only for our own children, but as we are working with families and parents and caregivers. So thank you so much for that. We don't have any questions yet emailed, so make sure that if you have any questions out there, email us and we will make sure those get answered. Now we're going to hear from Kathy Pounds, who is with Gift of Life and works in their nurse-family partnership and has done so for many, many years. And so she has a lot to share with us. So I will now turn it over to Kathy.
Thank you, Carolyn. It's great to be here today. And yes, Dr. Maxwell, that was a great job, a really hard act to follow, but I'm going to give it a good shot. So a little bit of background about myself and why the background I bring to talking and speaking on this. I was a staff nurse, started my career off in OB at Baptist Medical Center a long time ago in June of 1987 and worked there for about 10 years and then transitioned to the Gift of Life Foundation in August of 2002. And I worked there at first as a maternal educator in the public school system, providing education to pregnant teens, and traveled around the county to the different schools and just preparing them for labor and delivery and then encouraging them to get back in school and finish their education. And then in 2008, one of the board members at Gift of Life found Nurse Family Partnership, and we brought it to Alabama. We were the first site in Alabama to start Nurse Family Partnership back in 2008, and I have been with Gift of Life since that time as a nurse home visitor, and now I'm a supervisor of 5 nurses. We have built to a team. I have a co-supervisor. I built to a team of 10 nurses, and we service Montgomery County, Russell County, Macon County, and Autauga County, and are excited, looking forward to expanding into more counties in Alabama. So that's a little bit of background about myself and what I bring to the table to talk about safe sleep. I'm going to focus a little bit more on the challenges of following safe sleep practices. I want to identify for you what are some challenges that our parents and caregivers face, and what we can do as home visiting nurses and just healthcare professionals in general and caregivers. What can we do to promote a more open discussion about safe sleep practices? And I hope today you take away some new ideas that might assist parents in following some safer sleep practices. So a little bit about Nurse Family Partnership. This is my passion. I love what I do. Nurse Family Partnership was founded in 1997. It has over 45 years of research to prove that it works. It's an evidence-based community health program focusing on low-income first-time moms. Not only do we focus on low-income first-time moms, we're also focusing on moms that have additional challenges like homelessness, limited support, drug use, and mental health issues. So you can see how some of our moms are at those risk factors that Dr. Maxwell identified. We like to enroll our moms early in the pregnancy, preferably by 12 to 16 weeks, but one of the criteria of the program is to enroll them by 28 weeks of pregnancy. That way we have the opportunity to really develop a lasting relationship with that mom and build that trust so that we can be the person coming in and giving her some information and helping her. We stay with our families until our babies are 2 years old. Dr. Olds is the founder of Nurse Family Partnership. It is nationwide and also international. It is based out of Denver, Colorado. And Dr. Olds believes, I am going to read this quote to you. Dr. Olds believes there is a magic window during the pregnancy. It is time when the desire to be a good mother and raise a healthy, happy child creates a motivation to overcome incredible obstacles, including poverty, instability, and abuse with the help of a well-trained nurse. So that's what I get the privilege of doing, making a difference every day, hopefully, in someone's life. Nurse Family Partnership believes better worlds start with better families, and better families start with us. the first 1,000 days of a child's life is a vital opportunity to work with that family, to awaken the caregiver within that mom, and to help promote positive lifelong changes. We focus on what's that mom's heart's desire, and how can I, as her nurse, come along beside her, make that partnership, and help her focus on that heart's desire, and through small changes, make big changes for her life. The objectives of the program you see listed here. So when we talk about improving pregnancy outcomes, what are some of the things we can do or hope to do, and is proven to do? Decrease preterm birth, decrease hypertension, promote healthy habits with that mom, help my mom make healthier choices with her diet, healthier choices with decreasing smoking or alcohol use or drug use. How are we improving child health and development? We're helping that mom become the best mom she can be. Come along beside her, encourage her, support her, teach her about responsible, sensitive, competent caregiving. Model that for her over this 2-year period that we get the unique opportunity to be alongside that mom. Improving economic self-sufficiency, breaking the cycle of poverty, helping her to set goals. Oftentimes we ask our moms to dream. If you woke up tomorrow and your life was perfect, what would that look like? Helping her set some goals and dreams for her education, for her future, and like Dr. Maxwell mentioned, planning for that next pregnancy. When do you want that next baby? At Gift of Life, we are currently serving 191 women with 135 infants and toddlers. Our moms spend an average visit time with us of 50 visits during that 2.5 period when they have completed the program. Since the inception of Gift of Life, we are approaching 1,000 moms. 986 families have been served since the foundation of Gift of Life. Like I said, it's a partnership, it's a relationship, making lifelong changes in that mom. I often tell my nurses, if you get the relationship right, everything else will fall into place. So a little bit about our demographics and a little bit about the moms we serve. As you can see, 85% of our moms are African American, 9% are white, 3% are multiracial, 2% are Hispanic, and 1% Asian. When we look at the age groups of our moms, you can see that 23% of our moms are in that 15 to 20 age group. Dr. Maxwell identified that's a risk factor for that mom, that low teen pregnancy rate, that low teen age. 64% of our moms' age range is from 21 to 30. Most of our moms are single, never married, about 80% of our moms. 11% of our moms are not married, but living with their partner. You can see that we're making a difference and we're improving the self-sufficiency of our moms, but there's still room to grow. 88% of our moms have completed high school by the time they graduate from the program. 11% of our moms are furthering their education in college with a bachelor's or associate degree or even in trade school. And then when we look at workforce participation, when our moms have graduated from the program, 57% of the moms are working, and of that 57%, 67 is full-time. Really proud to show you these statistics that we're making, and I smile as I go through some of these slides because I got to pick some of my mom's babies, so I have memories as I look back through. 84% of our babies are born at a healthy weight. 82% of our babies are born full term. 56% of our moms have initiated breastfeeding, and 91% of our moms have received their immunizations. So again, you can look at these stats and see what we're doing to make a difference with those risk factors that some of those moms have. Full-term babies, healthy weight babies, breastfeeding rates, and immunizations are all those protective factors that Dr. Maxwell mentioned. Dr. Maxwell did a great job in teaching us a lot about sudden unexpected infant death. At the bottom of my slide, you can see the 3 most commonly reported types. And what I want us to focus on is that last one, accidental suffocation and strangulation. How can we help our moms with that? And how can we help educate them to prevent that from happening? As a nurse home visitor, this is something that we concentrate on in our visits. From the time we start with our moms, we're looking at risks that baby will have down the road, and we're preparing that mom to address some of those safety risks. So safe sleep is definitely something we address throughout our time. Dr. Maxwell also covered stats, so I'm going to slip through this slide. She gave us more up-to-date information than I have here, but really looking at, we've made some progress, like she mentioned, but when we look nationwide, we're still above the national average for our rate of SIDS. So when we think about that data that she had shared with us, you have to wonder, what can we do as a nurse home visitor and healthcare professionals to promote a safe sleep environment? So I have the opportunity to share with you a study done by a group of nurses in Goodwill, Indiana. They looked at 17 nurses, and in this study, they just were going to listen to the nurse home visitors, have a discussion with them about what education do you provide to moms. And then we wanted to discuss ways that nurses and healthcare providers can help moms be more successful with their safe sleep practices. A lot of moms believe that they are doing the best, that they are doing their due diligence, that they are providing the best protection for their baby when they're sleeping with their child. In this study, I will read this quote. In one study with enhanced messaging about safe sleep guidelines, African American mothers continued to bed share despite hearing that bed sharing increased the suffocation risk for that child. So if I believe as a mother that I am doing my due diligence and I am doing my best by having that baby sleep with me, it's really hard to convince that mom that she needs to provide that safe sleep environment, that gold standard that we all know about. So in this study, there were 2 overall themes were identified. First, we're going to discuss the challenges that the nurses found in following safe sleep practices, and then we're going to see the nurses' perspectives on how to better promote safe sleep practices. So one of the challenges was good intentions. Most of our moms start with good intentions. In this study, most of the moms started with good intentions. They plan on practicing safe sleep, and we find that in our practice at Gift of Life. Most of our moms plan on practicing safe sleep. But then, something happens. That baby is crying. He's sick. My mom is tired. For those of you that have been a caregiver and a mom, you know that feeling. Exhaustion, tired, my baby's crying. So, it's like I take that one time and I bring baby to bed with me. Now, one nurse described in this study, it's almost like that mom's hooked now. One nurse explained that some moms were afraid when their babies were sick that they wouldn't pick up on something or they wouldn't hear something if the baby was in its own sleep environment. And again, moms felt like they were doing their best when baby is in the bed with them. Another challenge that was identified in the study is keeping a secret. Sometimes moms hear the information and they're not planning on practicing safe sleep. So as their nurse home visitor, I don't know that, and I'm not providing more education. She wants to keep it a secret from me or from the nurses in the study too, because she doesn't want me to try to talk her out of it. And she also doesn't want me to think bad of her if she chooses not to do it. Culture was another challenge identified in the study. A lot of our moms live with their moms So grandmothers encouraged the mothers to take the babies to bed with them. They want the house to be quiet. They want baby to go back to sleep quicker, so they encourage mom to take baby to bed with you. One nurse reported that the grandmother told her the baby needed to be in her bed to stay warm. And remember, overheating is one of the risks of SIDS, but maybe the house was cold. Maybe our heat might be turned off. These are some of the challenges our moms face, so she brought her baby to bed with her to keep her warm. Oftentimes, grandmothers say, I slept with my baby, everything turned out fine. It'll be okay if you sleep with your baby too. Some moms in the study reported they didn't like leaving their baby alone in that crib. They would see them in the crib, they look lonely, they look by themselves. They were worried, so they choose to bring their baby to bed with them. Another challenge that was identified was crib death, misinformation. Whoops. There we go. One more time. Crib death. Moms have heard that term. They've heard that word crib death. So they think, does that mean my baby dies in the bed, in their own bed? So we as healthcare professionals, nurse home visitors, we're often battling misinformation. It can be misinformation from family, from friends, or maybe social media. Think about the pictures you see about oftentimes with moms and babies in their bed. Sometimes we normalize that and our families think that that's okay. As nurse home visitors, we have to be really careful how we address this misinformation. My mom trusts her mom, so I have to be really careful how I address that misinformation. Another barrier in the study was mistrust. Sometimes our moms don't trust us. Oftentimes in the study and at Gift of Life, some of our nurses are white and my moms are African American. So we have that barrier there. Are they going to trust the information that I'm sharing? And I really think as a nurse home visitor, you can overcome that barrier. It's all about the time that I spend with my mom. I come in early in the pregnancy. I gain her trust by sharing information, by respecting her culture. And this was also identified in the study. We really believe that we can overcome that barrier. It takes time to build that trusting relationship, and you have to remember that once trust is broken, it's hard. So we work really hard to do what I say I'm going to do. If I have a visit scheduled, being there, just things to create that trust and really show that mom that I'm there for her. I'm not going to bring any misinformation to her. The second underlying theme, remember we said there were two underlying themes in this study. First were the challenges or barriers that were identified. And the second theme was the nurse's perspective on how to promote the safe sleep message. So they wanted to know, why can't it be easier? Or the nurses came away from this discussion in this study thinking, why can't it be easier to teach about safe sleep and to have my moms practice safe sleep? It was identified in the study, we must do more than teach the gold standard. I must do more than teach alone and back and crib. I must be comfortable as a healthcare professional and in my home with my moms discussing that practice that she has chosen. If she's got her baby co-sleeping, I need to be comfortable to address that and maybe teach her some more risk factors. We need to educate mothers on protective factors if they're choosing to co-sleep. And I'll get into that a little bit later. How can I, as a healthcare professional, how can I adequately talk to my mom if she's going to choose to co-sleep or bed share? How can I adequately talk to her? In summary, looking at this study, mothers intend to follow safe sleep practices, but something happens and they change. A lot of women believe that they're doing their due diligence, that they're doing their very best by having baby in the bed with them, that they can provide the best protection then. Misinformation can play a role, but creating that trusting, respectful relationship is the key and essential to positive results. So after doing this, looking and finding this study that was done with a group of nurse home visitors in Indiana, we looked at doing kind of our own study at Gift of Life, unofficial study. So I had 7 of my nurses to get together, and we asked some of the similar questions. Wanted to know, what are the barriers? What are the challenges that our moms face when practicing safe sleep? This quote from one of my nurses: they usually show that they have the intention to practice safe sleep. It just seems like when it comes to doing it, it just falls apart. So very similar to what was done in the study with the nurses in Goodwill. They intend on doing it, but something happens. Even though we start education early off, our moms are very receptive to the education, but something happens. These are the reasons that our moms have given us and my nurses have identified. Moms say, baby doesn't like the bed. Mom can sleep better when the baby's with her. Being a tired mom, I'm tired. I'm breastfeeding. Might have a sick baby. So it becomes easier to have baby in the bed with me. Again, I keep saying it, but that vigilance, that safety, she believes she's doing her very best. Sometimes space in the bedroom is an issue, and it might be a tight space. There's not enough room in the bedroom to even bring a small crib or a pack and play. A lot of our clients are really mobile. They may be staying with a friend, they may be staying with a relative. Things change, they need to move. Sometimes they leave quickly. They don't plan and they don't take that bed with them, or even if they have a pack and play, if they're leaving out quickly, they don't think to grab that pack and play. So I also ask, when talking with my nurses, how do you address these reasons and concerns with your clients? So when you know someone might be practicing an environment of sleep that is not the gold standard, it's not safe sleep, how do you deal with that? So using our own experience as a mom and really relating to the client, letting her know I understand. Dr. Maxwell did that when she answered Katrina's question earlier. We understand how hard it is to place baby in their crib. You know that mom is tired. So really doing that and showing my mom that I'm not judging her, validating her feelings, recognizing that it is difficult, talking to her about things that might help. Ask her questions. So if she is practicing sleeping, co-sleeping with that baby, ask her what that environment looks like. Do you have a heavy quilt? Do you have a blanket? Who else is sharing that bed with you? Again, are we comfortable as healthcare professionals talking to our moms to try to make that environment a little more safe? It's not the safest, but how can I help her if that's her decision? I have to respect her decision. How can I help her make that environment a little safer? How can I teach her about the risk factors? Is that baby less than 4 months old? Was mom a smoker? Is there a smoker in the home? So educating her about additional risk factors when she's sleeping with that baby. Also ask my nurses, does it make you uncomfortable to talk about an environment that we know is not safe? As I think about providing education to my moms, it is a little hard because we are taught, I know the best, just like Dr. Maxwell presented, the best is ABC, alone, back, and in your crib. But I also am in my home with my mom, and if I know she's not practicing that as a healthcare professional, do I just leave it there? Or how comfortable am I with helping her problem solve? And keeping that conversation open and honest so that she feels like she can really talk to me and that I'm not judging her. So the more you do it, the easier it gets. That's what some of my nurses identified. Consistency at each visit. So if she's not practicing safe sleep, I know as a nurse, I need to talk to her about it. I want to talk to her about it, but I have to be careful how I do that so that she doesn't feel like I'm harping at her, she doesn't feel like I'm judging her, because I want to come back in 2 weeks. I want to be there for her. I've said show no judgment. And then after we provide education, using our own experiences. Some of the nurses talked about as moms maybe having a sick child and how they had brought that child to bed with them, and then looking back, sharing that own experiences, sharing how hard it was to get baby out of your bed once you have brought baby into your bed. Just being real with our moms really helps them relate to us. Also talking with the nurses. Sometimes a mom's been practicing co-sleeping and then she does move baby to her bed. What happened? What did you do as a nurse that helped her do that? When you were there with her, what happened? Consistency, we've talked about that. So just keep talking, providing encouragement and support. A lot of times on the visit, addressing the concerns you see. So if a mom has a baby in the bed with a boppy, talking to her about it. Lots of times we take a doll into the visits with us, showing her and demonstrating with that doll how that baby could become entrapped. You know, seeing a visual image and actually looking at it is different than us just talking about it. So really showing that demonstration helps. The last bullet point there, relating is the key. Again, get the relationship right and everything else falls into place. What's working when we're educating our clients? One of my nurses identified the handout that we use from Safe Sleep when it shows the crib with nothing in it. That's really eye-opening when you show it to a mom. I mean, I can talk about alone and on their back, but showing that picture and asking my mom what she sees, nothing. That's right. That's how that crib is supposed to look. We find that handout very helpful. One of the nurses discussed about, as a nurse working in NI, being able to be open and frank with her clients and talking about the dangers of co-sleeping. Again, it was a dad who had fallen asleep on the couch with his bed, and as an NI nurse, having that baby come in there and left with deficiencies, and being able to talk to that mom about that. The Safe Sleep Interactive website is also helpful. We use that. Moms can look at that and work through that. Sometimes we send that link to our moms before the visit and then pull it up when we're together. Again, demonstrations. Before the baby is there, when they have their pack and play or their crib or their bassinet, going in and showing mom, what does it look like when it's nap time? I'm going to lay my baby down, and showing her, and then having her practice. It seems simple, but when she goes and she's trying and she's having that frustrated night, she's going to remember what we talked about and what the safest way was. We do talk about things to help with our moms when we're on visits as far as comforting the babies. The 5 S's is very helpful. Talking about swaddling, side or stomach position, but I'm talking about when I'm holding my baby and rocking my baby to get it to sleep, I will be holding it in a side or stomach position, shushing, swinging and sucking. So teaching those moms about those things that help, those 5 S's that help get baby soothed and quieted down, and then laying baby to crib in its own safe sleeping environment. Agree? There's lots of information out there about swaddling, and the takeaway factor from that really, as a nurse home visitor, what I teach my moms, once that baby can start turning over, we don't advocate for swaddling anymore. So how can we help our clients be successful in practicing safe sleep? A lot of these I've already covered, but one of the things I like, and I will share a little bit later in the presentation, is just sharing some risk factors and being comfortable and knowledgeable enough as a nurse to share some statistics with her, such as soft bedding increases the risk of death by 5 times. So if my mom is telling me, you know, I'm co-sleeping, I understand that. I know it's hard. I know you're tired. I know you're struggling. But is it all right with you if I share a little bit of information? Are you aware that soft bedding increases the risk of your baby having SIDS by 5 times? You know, it's one thing to just tell her it's dangerous, but when I can give her a little stat, maybe that helps more. How about, I know that you get tired and it's hard days and dad's on the couch, but are you aware that couch sleeping increases the risk of SIDS by 50 times? So maybe having some of those stats in my toolbox as a nurse home visitor or a healthcare professional, so I can really customize my discussion about safe sleep with my mom and how she's practicing it. So we're also making sure that moms have a safe sleep environment, helping our moms access a pack and play, and we do that through Cribs for Kids with the ACHN care coordinators. So those are things that we can do and are doing that help our moms be more successful in practicing safe sleep. I found this website from North Carolina as I was doing research for the presentation today, and they do a great job of illustrating and providing some resources that help you as you're addressing this conversation with moms. Using a strength-based approach, this helps the family feel more valued and not judged. Really using open-ended questions to start this conversation about safe sleep is very helpful. Open-ended questions are questions that my clients have to answer without telling me yes or no. When I first started doing this type of nursing, that was a big change for me, because bedside nursing, I've got a checklist and I'm going down, and most of the time I just need you to tell me yes or no. Have you had this? But when I'm in the home with my mom, I want a conversation. My visits are an hour long, 30 minutes to an hour long, and I've got time before this baby is born. So I want to talk to her and offer her questions where she has the opportunity to talk back to me. So what about this question? What do you like about bed sharing? So if my mom tells me she's bed sharing, let's be honest. Let's have a dialogue. What do you like about that? What benefits? What do you think the benefits are for you doing that? And then validate that. Let her know I understand. That's real. And then asking her, could I share some information with you? These are some open-ended questions. What have you heard about ways to keep your baby safe while they sleep? Those S's are getting me. So what have you heard about ways to keep your baby safe while they sleep? That's different than me coming in and saying, let me teach you about safe sleep. It opens the conversation and she gets to talk to me. What plans have you made about where your baby will sleep? You know, we do a lot of discussion around that, around breastfeeding. Instead of asking my mom, do you plan on breast or bottle feeding? Tell me about how you plan to feed your baby. So again, tell me about how you plan for your baby to sleep. Where do you want your baby to sleep? So it opens up that conversation. Several other questions are listed on this slide, but having in your toolbox 1 or 2 questions that you're comfortable saying so that you can open up that conversation to talk with your mom. Again, on the website, this has a questionnaire that you can use. So telling our moms there's no 100% safe way to bed share. So she has told me, I'm there on a visit, and she's told me, hey, I'm co-sleeping, so I'm going to let her know. You know, there's no 100% way to make this environment safe for your baby, but let me tell you some additional risk factors. If your baby was born less than 37 weeks, that's an additional risk factor. It is increasing the risk of infant death. Was your baby born weighing less than 5.8? So a low birth weight baby. So if I know my mom had a low birth weight baby, I need to let her know. You're increasing that risk. It's a greater risk of time to bed share when that baby is less than 4 months old. If mom smoked during the pregnancy, she's also increasing her risk, or increasing that baby's risk. Then when we talk about the person that is also sharing that space with mom, so if her partner is there and she has a baby in the bed with her, you're increasing the baby's risk of death if that partner smokes or vapes, or you smoke or vape, has taken any medicines or drugs that might make them sleepy, has had any alcohol, and is not the baby's parent. So letting my mom know that if she's co-sleeping and any of these risk factors are there, the baby's risk of infant death is greater. Another thing, when we talk about the sleep space itself, so if I'm looking at mom's bed, what about those big fluffy pillows? What about that big blanket? If you're going to do this, pull those back down. So letting her know that even increases the risk. The couch or the recliner increases the risk. Are there multiple people in the bed? And that can be other children. That increases the risk. I've included the QR code in the slide. You can scan that and it'll take you to North Carolina's Safe Sleep site. They do, like I said, an excellent job of providing us some resources that we can use with our moms that help us talk about environments that are not the gold standard, that are not the ABC. Yes, we need to teach ABC. I need to teach alone and back and in her crib, but I also need to be comfortable helping my mom identify solutions and what the best practice is for her. On Cribs for Kids, I mentioned this earlier when I was giving some of those statistics. So there are talking points in there. And so as a nurse, I can go in and look. If I know that my mom is placing her baby on her stomach to sleep, going in and letting her know that that increases the risk of death by 21 times. And if that baby has been generally placed on its back, and then I place it on the stomach, I'm increasing the risk by 18 times. And if I do both of those together, I'm increasing the risk by 40 times. So there's several talking points. So you could personalize your discussion with your mom by going through and looking at the talking points and just having that stat and in conversation, just saying, hey, is it all right with you if I share a little bit of information with you? We've been talking about safe sleep. I realize you're co-sleeping, but I've done some research, and would it be all right if I shared with you the risk factors there? So helping my mom become more aware of the risks that she is taking. So next I would like to share with you the slide that's going to let you see American Academy of Pediatrics Safe Sleep Guidelines. So I'll see if we can get that to play. So that concludes my presentation today, and I guess the takeaway that I hope everyone has is that just being comfortable and having that discussion with your parents and caregivers, if they're not practicing the ABCs, how can you as a healthcare professional be comfortable sharing that information, using those open-ended questions, validating their concerns, showing the client that you understand, and then helping them to problem solve and reach a solution that is best for them. So thank you for your time today, and Dr. Maxwell and I have time to answer a few questions if there are any.
Sure. Thank you, Kathy. That was a great presentation. You brought up cribs for kids. They can also order those cribs through Alabama Department of Public Health. All you need to do is go to our website, go to the perinatal division, and then there's a topic on the left side that says Safe Sleep. It will be on there. There's some information. If you scroll down, the forms are right there and the contact information. So, and I think that's who ACHNs actually use, is to come through us. But I'm glad they're doing that because they see a lot of moms and babies. One thing that came up just yesterday, Amy McAfee had gotten a call that somebody thought they couldn't order those cribs until after their baby was born, and that's not the case. It is within the last 4 weeks, so 4 weeks before delivery they can actually get that crib. So that's there for anyone who needs a safe place to sleep. So we have that available. We don't have any questions yet, but we have plenty of time for questions, so or discussion. So what questions do we have?
I was wondering, Kathy, you did a great job of talking about how to be empathetic with your clients and that type of thing. The one topic that I think would be especially difficult is when that trusted family member or friend says, oh, it's okay if you sleep with the baby, if it's the grandmother or the auntie. How do you address that with your clients?
A lot of times the grandmother, I refer to her sometimes as the gatekeeper. And I do think about, as a nurse, how would I feel if someone was coming in my home telling my daughter about what was best for her? As a mom, I kind of know what's best for my daughter. So working hard to gain the trust of the aunt or the grandmother, inviting her to come in and be a part of the discussion, validating how she feels. Like Dr. Maxwell said, when we know better, we do better. Some of my children that were born were before the Back to Sleep campaign. And really just letting that mom know, I appreciate her. Her place in her daughter's life is different than mine, and I'm coming to her with new information, suggestions, research. But at the end of the day, and this is what's hard about being a nurse home visitor, at the end of the day, I have to respect my mom's decision to make a choice based on what she thinks is best. It's my job to educate her and to keep educating her. So I want to do that in a way that that mom accepts me too. One of the principles of nurse-family partnership is that the client is an expert. Does that mean that she does everything expertly? Who of us as a mom can say, oh, I did everything every time, I was an expert? No, but most of the time. Moms have good intentions. I'm doing what I think is best for my child. I don't want to do anything that's going to harm my child. And the same with my mom's best intentions. So we come at it from the frame point, the client is the expert. She gets to decide what's best. It's my job to come alongside her, to be her partner and educator, and doing the same with her family members, inviting them to be a part of that discussion. I want to win their trust too.
I think that's really hard when my child was born in 1984, so it was long before the Back to Sleep. And back then, we put them on our stomachs because we were told if you put them on your back, they're going to aspirate. So if my daughter was on her back, I was just terrified that she was going to die. And I think that's where those grandmothers come in. They've heard that fear over and over again. And it makes sense unless you can see anatomically how that's impossible. So I think that's a really hard barrier to get through with some of our grandmothers.
And we do think
particular.
that, you know, that that's a choking hazard, but when you can show that picture anatomically and explain that to the mom and let her see that that's not the risk. You kind of think it might be when you first think about that,
Right.
but being able to show her that picture and have that discussion.
Yeah, that's a real challenge. And when I'm looking at these trainings, it's a miracle my child survived the first 2 to 4 months, because I did everything we weren't supposed to do,
Mine too.
including having the beautiful crib and the bumper pads and
Yes.
matching pillows and everything else that went with it. So, but we have come a long way. And you can see from our data where we had that Back to Sleep campaign, it really did drop. But
Yes.
unfortunately, we haven't gone any further than that. And so that's a real concern. Have you all done anything with the daycare centers in training? I know that we have that in our division with our HICA nurses that go out and train in DHRs, but have y'all had any experience with that in education with Safe Sleep? Because from your presentation, there's a lot of deaths that occur actually in the child care centers too.
So I haven't, my interaction is more with parents, and when I used to do a lot more pediatrics, just counseling about that. And what I would always tell my parents is, this is what the textbook says. Now, you've had this child, you've been a parent before, and so you have to temper that with a little bit of humility, because here you are coming telling me what's best. Well, I can tell you what the books say, and I can tell you that this is the risk, but ultimately it's your decision. Now, I may not agree with you, but I want that parent to feel as if they've had the information, and then they make the best decision that they can for their child. So, my interaction is different because it's more so with parents, and I think you're more so with the patients or clients as well. So.
And that's going to be hard because parents have to work and they have to depend on that child care, the one they can afford or near their home.
Yeah.
And then when they see those risk factors, hopefully they're speaking up as well.
Yes. Teaching our
Sure.
clients and moms to be advocates for themselves, whether that's at the daycare or a caregiver's home, but teaching them to be advocates for themselves and their babies.
We were talking to a pediatrician recently on the phone. Actually, it was Dr. Stubblefield. And what he did to address it with parents, and he was talking about sleeping on the sofa. And his response when they said this is what they were doing is, well, is the 5 times risk of death, is that worth taking in your decision? Is that worth it to you, knowing that your baby has 5 times greater chance of dying that way? Which I thought was a good approach too.
Yeah, like
Acknowledging that's your decision, and is that a risk you're willing to take?
Yeah, I agree. I think something that I took away from this and doing the research for the study was to have some of those statistics. Not that I'm just coming at my mom with those statistics, and I might have to go look it up. But okay, she's couch sleeping, so knowing where those talking points are. So when I go back, or she's told me that's what she plans on doing, baby's not here. So when I go back, I can have that information and in my conversation be able to say, hey, are you aware that that increases the risk by 5 times? That's something that my mom can really, instead of me just saying, it's risky, that's going to make her see a little bit better, I think.
But I liked the idea too that you're acknowledging this is what your decision is, so how can we make that safer?
Yes.
And I think that's great. What other comments do you all have? Questions? Did we have someone call in?
Hello?
Yes. Yes, you're on. What's your question?
I forgot a question. My question is to Kathy Pounds, the nurse. What's the death rate for the Hispanic babies, and what has Nurse Partnership done to reach out to that population, those moms? Because I noticed she said the rate, the enrollment was kind of low on that percentage of Hispanic moms in the Nurse Family Partnership program, so I was just curious about that. Thank you.
for that population as far as their risk with SIDS. And so to answer your second question, but we can look for that and get back to you. But to answer your second question, what are we doing to reach that population? We receive our referrals through various sources. So it can be through crisis pregnancy centers, through the ACHNs. We receive referrals from doctors' offices, from word of mouth. So really from the health department, from WIC. So we're relying on the community and other resources to get those referrals to us, to let us know about those moms, to reach out to be able to support them.
Okay. Do you think it's a lack of trust?
I would have to go back and look at our statistics to see how many moms that we have had referred to us. I think we do a really good job of converting those referrals. A barrier that is sometimes there, of course, is the language. We, at Gift of Life right now, don't have anyone that is speaking Spanish, so that could be a barrier for them joining the program. And, you know, it can be lack of trust. We have to think about those things and work through those things, but I have had some Hispanic clients, and again, as we come in as that nurse home visitor and spend time with her, we earn her trust. She may not trust me at first, and I could say a lot of my moms don't trust me at first. You know, I'm coming into their home, as the expert here, they may view it that way, so we have to earn that trust, but that could very well be a barrier.
I think maybe a key to that is the person who's referring, helping them to understand the importance of this, and maybe starting the establishment of trust with that referral source as well.
Yes, a lot of, that's a great point that you make, Carolyn. A lot of our conversions have to do with how the program is presented on the front end. If there's a buy-in on the front end from whoever told her about us for the first time, that it can be very helpful as far as us being able to reach that mom and being able to serve her. You know, it's not all about numbers, like when I'm saying conversion and that referral. Really, to me, that's not what it's about. It's about reaching that mom and supporting that mom. So it's in how it's presented that she would trust us. So that's a great point that you make.
Do you all use the language line when you go out,
Yes.
since you don't have an interpreter?
Yes,
Which
we
I
do.
think most of our Hispanic clients in this area, at least in the Montgomery area, are very accustomed to that.
Yes, we do use the language line. I
Thank
hope
you for
that
your
answers
question.
your question.
Did you have any more
It did.
questions?
Thank you. It answered. Thank you so much. Bye-bye.
Bye-bye.
Do we have I see a question from Madison County. Was that the one we just had?
That's a new one.
Okay. Oh, it's a new one. Okay. Next question.
Okay. As working with one of the ACHNs, whenever I'm doing my delivery encounter and the mom absolutely does not have a crib or bassinet, what is the safe sleep arrangement that I could suggest for them?
We have two people here that work with the Cribs for Kids. Do y'all want to answer that question?
Sure. Well, so the drawback of the Cribs for Kids is that it does take a few days. Once the paperwork is processed, it takes 2 to 3 days for UPS to deliver the crib. Are you asking about sort of an improvised suggestion until the crib gets there?
Yes.
So an emergency...
I have used the Cribs for Kids before, but if I'm talking to them and doing the delivery encounter, and say it's the first time that I've spoken to them, and do you have a bassinet or a crib, and they don't have either one, I then suggest the Crib for Kids and get that processed. But in the meantime, what can you suggest that they use that's a safe sleep arrangement?
So I know that the AAP guidelines had said in emergency situations as a stopgap they could do something like use a drawer. or even, if necessary, something like a cardboard box.
Okay.
Kathy or Dr. Maxwell, do y'all have anything to add to that?
Those were what came to mind myself too. Firm, flat surface. So those would provide that in an emergency. Firm, flat surface. So the drawer or a box.
Okay.
Great question.
All right, thank you.
Any other questions that we have? We got a few more minutes.
Oh, can I clarify? The drawer, of course, should be taken out of the dresser.
Yes.
Just to clarify.
And make sure that our parents understand that. Yes.
And no lid on the box, no closing the box.
And on the ground too, when we talk about that. You know, sometimes with the boxes, and on that website, when I've done research about that, we think about the boxes. A risk with those is when we lay them on a surface that's countertop or on the bed or a dresser top. The box needs to be on the floor.
And sometimes we assume that people will know that, and I don't think we need to assume anything, and make sure that we've got those instructions down when we're talking to parents about that.
Yes.
So, have you had any cases of, one thing that I've been concerned about are shelters, when people are living with homelessness and not having a place for the baby to sleep. Have you encountered any of that in nurse-family partnerships?
Yes, we do. And we're working, work hard to get that mom to a place, whether that's with a relative, a friend, emergency housing, could be working with resources to get her in a hotel, but then providing that pack and play. So early on, knowing that we can get that as, 4 weeks before that baby delivers. So having that and letting that and teaching mom, this is something you need to take with you if you're moving from place to place. We work, if we have a mom that's truly homeless, we're working to get her into some type of shelter before that baby is delivered, whether that's emergency housing, finding resources to provide her with a hotel room for a few nights until we can do something else. Of course, as you know, in Montgomery, that is one of our challenges, is housing. And emergency housing is a great need that we have. For population, but especially from my end, in doing what I do, my pregnant moms, I want them to have a safe place.
And I'm concerned that many of those shelters may not have room for the pack and play, so they're having to co-sleep. That has been something we've been thinking about, and how to manage that.
Yes.
So, and I'm sure it would be for staying with family members, and where do you put that? So that puts our babies at risk as well.
Yes.
Is there any update? Are y'all, I know that many of the people listening today know about the expansion of nurse-family partnerships through Medicaid. Is that something that Gift of Life is pursuing, or is that something you can talk about?
Yes.
Give us an update on that.
We're excited about the expansion with Medicaid, with Nurse-Family Partnership, and we're in the process of deciding which counties we're moving to. But yes, in the future, we'll be making those announcements. But Gift of Life is looking at expanding in some surrounding counties more than we're already serving. Like I said, we serve Macon, Russell, and Autauga with Nurse-Family Partnership, so we are looking at expanding into some of the surrounding counties.
That's wonderful. For those that don't know, Medicaid is going to start reimbursing for nurse-family partnerships across the state, and I'm hoping that that will make an impact as well.
Yes.
In improving our infant mortality rate. We at Public Health and the Perinatal Division are very excited about that and that possibility. So, any other questions or comments before we close? Well, thank you so much, Dr. Maxwell and Kathy, for being here today. The presentations were excellent. Gave me some things to think about as well. This concludes our program for today. Please remember that you can refer back to the training and resources on demand anytime at alabamapublichealth.gov. Have a great day.